So validity. Validity is what we've been talking about with completion rates and participation rates. Does your data say what you say it measures? Another part of validity then is the properties that are built into the instruments. So this morning, Mark talked about the different kinds of validity, face validity and content validity and all those different things, discriminant validity that our researchers worked so hard to do when the shoulder cat was developed and so on. But as we all know, validity doesn't stop when the paper gets published. So it's up to us to maintain the validity of the instrument in the clinic. And we do that in what we say and what we do and what we don't say and what we don't do with the patients. And I want to make it clear, nobody thinks that anyone is getting up in the morning and saying, hey, I'm going to bias my outcomes, or something like that. I know that whenever we say things to the patients, whatever we do, it's with the best of intentions. And I truly believe that. I've done it myself. Folks I've worked with, it's with the best of intentions. Going forward, we're just working to fine-tune some things to further improve our standardization and building for the future. So there are two components to this part of minimizing the risk of bias. One is rolling out new instruction screens, and you have those in your slides. In the interest of time, I'm going to ask you to hold comments and questions for after this session, but I really want to hear what you think. So grab me this evening, tomorrow at breakfast, on the break. My email is in there. It's deannahayes@photoinc.com. You want to set up a phone meeting in the next couple weeks or something, just let me know. I will make myself available to you and really want to hear. But a lot went into this new standardization. We researched extensively precedents by other instruments, feedback from our users, and what are common problems that we have with administering questionnaires and difficulties that patients have with the questionnaires. We even delved into the field of education, because the education people have really done the best job in standardizing test administration, right? Because they have a really high, it's a really big deal for them. So a lot has gone into what are the minimal elements that we really got to have on the screen, and ideally we really want the patient to hear verbally. So whoever sets up the patient on photo, it's really best if that person says what's on the introductory screen. Now remember, scripting, by definition, means it's okay to paraphrase. Okay, you don't have to read the screen, blah, 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 blah. It's okay to paraphrase, okay? But what's on those introductory screens, don't assume the patient will read it, because we know they often don't. It's ideal, it's optimal for them to hear it verbally. Okay. So that's the intake screen and the status screen. And so just to recap, they point out to the patient to answer the problem with respect to the condition we're seeing you for, and answer the problem based on how you've been over the past few days. Now, minimizing the risk of bias. You know, it's one thing for me to stand up here and say, avoid interpreting the questions for the patient. But how many of you had a patient who's sitting doing their photo and they turn around and they say, how do I answer this? Okay. So you get that. And what do you do? Because it is tempting to just tell them how to answer. So some general guidelines to help avoid interpreting. Reread, re-emphasize, and objectively restate. And if we simply stop and just apply that to what's already on the introductory screens, a lot of times that just means calling them back to that. Remember, Mr. Smith, to answer this with regards to the problem we're treating you for, your knee. Okay, that's okay because it's already there. You're not biasing or changing anything. It's okay to call their attention back to that. So that's an example of that. And if you're following along in the printed slides, the next one is on tips to avoid interpreting. We're going to apply this to an example using the fear avoidance beliefs physical activity scale, everyone's favorite, right? So the short version on the side is if you want to learn more about how to use the FABQ and other aspects of fear avoidance and psychosocial care, just grab Mark, grab me, anytime, and there's so much more on that to really make it a rich part of your clinical experience. In short, even though it seems like a goofy worded question, tons of research has been done in the US and outside of the US, and really good validity and reliability. Despite that people have difficulty with it, the outcome of their answering it's good data, it's useful. So tips to avoid interpreting. So the FABQ, I should not do physical activities which might make my pain worse, or I cannot do physical activities which might make my pain worse, as a couple examples. And you know they have the rating scale from 0 to 6. So if we apply the reread, re-emphasize, objectively restate, one thing you can do is whatever's on the computer screen, it's okay to help the person by saying, okay, so Mr. Smith, it's asking you to rate your level of agreement with this statement. Okay? That's a reread. Re-emphasize, you know, Mr. Smith, it's asking you to rate your level of agreement with this statement. I should not do physical activities which might increase my pain. I should not do. Okay, so it's not a bad thing to emphasize, because that is the distinguishing part of the question. One says I should not do, one says I cannot do. Okay, you're just re-emphasizing. Or objectively restate. Mr. Smith, how strongly do you agree or disagree with this statement? I should not do physical activities which might make my pain worse. Restate, re-emphasize, objectively restate, or paraphrase is a way to say that. In short, there are, remember, some times when it is okay to actively help the patient. We have new processes in place for proxy and recorder. A reminder that if the recorder does not influence the patient responses. The recorder is only recording the answers, and so this is in PI Web now. There are fields to specifically say why the proxy is being used, who the proxy was, whether the proxy lives with them, and similar for the recorder. So we gather that data at intake, and the plan is for research analyses to be done on this and see how that pans out. The other part of this new proposal that we have for fine-tuning our standardization includes a set of supplemental instructions that would be made available to you. So the purpose of these is to say, okay, verbally, when the patient needs help, these are some examples of what's okay to do within the validity of the photo instruments. So one thing, it's okay to say, there are no wrong answers. We want to know what you think. So a lot of times with the FABQ question, for example, Mr. Smith, how strongly do you agree or disagree with this statement? I should not do physical activities which might increase my pain. Mr. Smith, there are no wrong answers. However you interpret that is the right answer. Just trying to give him the confidence to whatever feels right, that's the right answer. And indeed, however he perceives it, that is the right answer, despite what I think. That's the right answer. These are patient-reported outcomes. If you're asked about something you haven't tried recently, estimate how hard you think it would be if you tried. So for example, the 85-year-old who, oh no, wrong example. If your patient who is a runner and just hasn't had a chance to try getting back to running yet. Well, I haven't tried that lately. Well, estimate how you think it might be if you tried it now. And again, there are no wrong answers. Whatever comes to you is the right answer. Or if the question does not seem to apply to you, choose the response that's the best fit. So this might apply to an 85-year-old who turns around and says, honey, I don't run and I'm not going to. Well, whatever is the best fit. Remember, Mrs. Smith, these questions are with respect to the condition that we're treating you for. Because of your knee, do you have difficulty running? And then whatever feels like the best fit response to her is the right answer. Additional supplemental instructions that are proposed. This one has kind of been pilot tested because Mark Werneke's MDT group has been using this. Like he said, they load 5 psychosocial optional surveys, and some of the questions get a little sensitive, and they had some difficulties. So this is kind of a pilot tested scripting that would be suggested if you use a lot of psychosocial questionnaires. You might consider giving this additional verbal instruction, and you can read that there. I'm interested in learning more about how your condition may or may not be affecting you either physically and or emotionally. So imparting that value in a way that helps minimize the bias. Additional supplemental instructions that we're proposing to become standardized. This is another application to that scenario of the 80-year-old who is being asked if they can run, and that's not something that they do. Keeping in mind there are 80-year-olds who run. So some examples of minimizing bias in how we help the patient. The computer doesn't know you. It doesn't know if you're 18 or 100 years old. And this kind of comes to some of the feedback I've gotten from users and patients when the patient finds the question a little offensive. Have you ever had that, where the patient's a little irked because they're being asked if they can run? So the computer doesn't know you. Another part that I pull out sometimes when they feel irked by it is go back to what you know about computer adaptive testing and point out, that the computer is assessing how you're doing, and in order to find out what you can do, it has to find out what you can't do. Kind of like math testing in school with my 12-year-old. It's got to find out what you can't do in order to assess what you can do. Another common scenario that we hear about is post-op rotator cuff repair. So the question that they get is, can you reach a shelf at shoulder height? And I'll tell you, I used to just tell them. They'd turn to me and they'd say, well, how do I answer this? And I'm like, well, you're not supposed to do it, right? So you can't. And I just kind of step back and reevaluate that I did that. So let's say the patient says, hey, I'm not supposed to raise my arm. My doctor told me not to. How do I answer this? So the patient just said that. So I can paraphrase, that's not a problem. Well, in your own words, Mr. Smith, you just said you can't do that, or you're not supposed to raise your arm. Remember, the survey instructions asked you to answer based on how you are recently, the past few days. If you keep those things in mind, however you answer the question is correct. So give them that confidence to answer with what feels right to them. Even though my perception as a clinician was always, well, if they can't do it, they can't do it. What if the patient is like, well, if I had to, I think I could get my arm up there even though I'm not supposed to. So let's say they choose to answer yes with some difficulty or moderate difficulty. That's the right response, whatever they perceive it to be. A few things I didn't put on the slides that have always been part of what we promote to you and that haven't changed. It's okay to tell them how long it's going to take. 5 minutes, or if you do a lot of optional surveys, you might say, hey, this may take you 5 to 10 minutes or whatever. It's okay to give a time estimate. It's okay to say that there are going to be satisfaction questions on the status, and the part about information being a confidential part of your medical record. We're just probably going to take that off the introductory screens to make them shorter, but that's still completely acceptable to say. Thank you for letting me breeze through that. I wanted to get through it quickly in the interest of your time. Again, really want your feedback and your thoughts on that. We're looking at, we wanted to run it past you guys before we finalize some things. So thanks in advance for your feedback.
Now, why is CBT, cognitive behavioral intervention, so important? First of all, it should augment your treatment box. So this is an augmentation of what you naturally do traditionally. Well, it's very complex, okay? Especially patients will look at this biopsychosocial model as it was designed by Gordon Waddell for lower back pain patients. I think it's simpler just to pick on low backs. And what a traditional therapist will normally do is evaluate the patient's physical impairment. They'll capture functional measurements and pain measurements. And then based on that information, they'll start their treatment strategies. Well, that may work for at least 25 to 30, 35%. You can get high fives for 30 to 40% of your patients. But there's many, many other issues that may be controlling your outcomes if you have to expand your screening process to look at other things. So, example, have you heard the terms yellow flags? Is that common? Have you heard that term? So yeah, you're talking about what? You're talking about the patient's fears, their emotions, their behaviors, their beliefs, what have you. And you should screen for that. And there are many, many different psychosocial models out there that you can choose from. And most people, from what I hear, are more comfortable with the fear avoidance model, which is fine. That model will probably work for many patients. And then blue flags. Does anybody work with patients in workman's comp? Well, there are certain blue flags that are confounders to outcomes. They may not want to go back to work. Why? Because they're afraid of their supervisor, or they may be penalized by their employer. So usually in a work comp setting, it works best when the employer, the insurer, and the patient and the therapist are all working together in one unit to make sure that these pathways don't occur. Now, black flags. I talked to another person earlier this morning that they see a lot of Medicaid and those seeking Social Security disability. Well, it's ominous. It is a black flag because they may predict worse outcomes. And if you look at payers, what Daniel went over just a little while ago, he didn't get into its specifics, but payer, Medicaid, or Medicare less than 60 years of age, are important predictors of worst outcomes. So you need to be aware of that if that's going on. And then the risk-adjusted factors. Many of these are just non-modifiable, but you should pay attention to that because it's going to help you decide on your efficiency. And then clinician factors. It's pretty important. We already know from Linda Resnick's work over 10 years ago that clinician characteristics that was reemphasized again by Daniel, or therapeutic alliance development, is very important and powerful predictors of outcomes independent of the treatment that you're doing traditionally. So there are many things to consider. Okay, so screening for psychosocial factors, what's available right now as optional surveys in photo? It's your fear avoidance of physical, which is mandatory, right? That is a risk adjusted. And also work activities. There's catastrophizing, which is a subset of the fear avoidance model. So if I think you're collecting fear, do you have to collect catastrophizing also? Nah, probably not. Psychosocial distress. I was very interested in this because both the depression and somatization, if you use those together, can classify your patient into high, medium, and low risk. So that's a wonderful tool because classification is useful in starting to target treatment-based interventions. So if we knew how to classify our patients based on their level of risk, that's a strong advantage, and we should seek those tools out. And then the START tool. Okay, our particular research group went to the START tool as soon as it was available. And you'll get, again, classification. This is for lumbar patients. Some therapists have tried to use it, or research groups are using it for cervical patients. I think you could use it for any spinal type patient, you just can't publish it, but you can learn from it. It's still clinically important to apply the START to spinal patients, but it was designed for lumbar. It's a very useful tool. And then there's self-efficacy. That's what's currently available in the photo optional survey lists. Well, how many therapists in photo are currently selecting psychosocial optional surveys? Well, in our paper in 2011, physical therapy, 3% of therapists in the photo data set are turning on psychosocial surveys. So that may be a problem in effectiveness and efficiency equations if you're interested in value. Okay, because you have to make some decisions on how these things change. Okay, now just to take a look at our research group, we've worked very hard on collecting psychosocial data, and over years of training, we've gotten the frequency or the percentage of psychosocial screens turned up to at least 50% of our patients. So again, with effort and with education, you can start using these tools. Now, the big hurdle is, how do I use those tools to manage my patients effectively? That's a good question. This was the fifth tenet that we introduced this morning, that this screening process for psychosocial issues is quite important. Advantage out if that psychosocial screening process classifies your patient. Now you can target patients at high psychosocial risk for cognitive behavioral therapies, which can be performed at the patient's bedside or during everyday clinical practice by physical and occupational therapists. Now, just because somebody comes in at high risk, It doesn't mean they have to go see a mental health specialist. Not at all. And we should watch and not do that. They should stay within physical therapy. They may be appropriate depending on what? How things change over the course of your treatment episode. So serial assessment is just as important for psychosocial classification as it is for monitoring your FS values. Okay. So cognitive behavioral techniques, there's two types. Something I'll call meaning responses, which is the umbrella word for therapeutic alliance. It captures your clinician communication skills and your mannerisms. And also, there are advanced cognitive behavioral training programs for patients classified specifically at high risk. And the whole purpose of this is to create positive response shifting. You want your patients and turn the sick talk into well talk. Okay? And you can use these these are meaningful responses. Okay, so meaningful responses, again, are therapeutic alliance. Well, what is that all about? Well, this is what we had talked about, or Linda found over, 2003. This was shown a long time ago. And just recently is Therapeutic Alliance being published in physical therapy journals since 2012, 2013. So it's become recent. They're starting to recognize it and giving it labels. But we recognized a long time ago that your characteristic of how you collaborate with your patients and how your patient-centered care approach is very, very important. And that's what Therapeutic Alliance is. And when does this develop? Probably not on the first visit. So there are ways actually to measure Therapeutic Alliance, and it's a 9-item survey that's not in photo yet, but it's certainly something that should be on the photo development agenda. And so if you want to find out what alliance is going on, we can start looking at that and then looking at actual outcomes with FS later on. But I think what's really interesting here is that not only that collaborative relationship, but this is the bullet. And I can see this. If patient has trust and confidence in your ability to function effectively on their behalf, you've caught the fish. And now you start getting them involved in what they need to do. And that's their problem solving with what they're learning in therapy, and then they take it home and apply it to their function, to their ADLs. Okay? Now, recent evidence on Therapeutic Alliance. Again, this was almost 10 years later from the Linda Werneke paper. This was by Hall in Physical Therapy at 2012. It was a systematic review, and it included 13 papers. Results were, well, that Therapeutic Alliance is positively associated with treatment adherence, patient satisfaction, improved physical function, both in geriatric patients and those with chronic low back pain. That's fairly interesting. We know that the link between pain and function is convoluted when they have chronic pain, and we have to deal with those misconceptions. Well, geriatric patients also respond very nicely to a strong therapeutic alliance. Okay, and this is a paper by Ferreira, Physical Therapy 2013. This was an RCT. So it was 182 patients. They had 7 participating therapists, and they did use the Working Alliance Inventory. This was a 16-item, but there's further research that suggests that you only need 9 items to be more efficient in measuring therapeutic alliance. And the results were the same, and they're quite consistent. And we've observed that in a qualitative study a long time ago. That therapeutic alliance is associated with improved outcomes, and they looked at 8 weeks. Okay, meaning responses. What else may be captured under that? Well, communication. I think we're very good at doing this as a profession. This is meaningful, and you should praise and have attention to any positive behavioral scenes. I think we do that. It's just really part of cognitive behavioral treatment. You start asking questions that build self-efficacy to the patient. Well talk versus sick talk. These are common terms you may have heard. It's a patient-centered interviewing and goal setting. Get the patient involved in problem solving, and you've got it made, because now they have strong buy-in. Not problem solving in performing, well, are they adherent to home exercise? No. How are they problem solving their functional movement strategies while they're vacuuming or picking up groceries? Things that we heard about early this morning where they're marrying the exercise to support the function. That's a pretty strong approach to cognitive behavioral interventions. And clinician mannerisms. You think it's important? Okay, here, take the photo survey. I got to finish my coffee. I don't think you're imparting value very well with that. But I see it happening with other clinicians within the hospital system. Your mannerisms and how you yawn or you're not really connecting with the patient, just not going to work. So you may not say a thing, but you lost the patient. It's possible. And that's a lot of energy, isn't it? We have to stay up even when we don't feel well, when we're managing patients to develop therapeutic alliance. Yeah, it is. Okay. Meaning responses. Is that the same as placebo? Well, if you read the slide, it's not. So I'll go along with the slide. But placebo treatment is inert. Okay? There is no active treatment ingredient. But a meaning response is active ingredient to your treatment. It's meaningful, and it's directed, and it has a purpose, and you're using that to improve your alliance with that patient. And you want them that they feel that you have committed on their behalf to improve their quality of life. So it encompasses the patient and management strategies from a psychosocially informed perspective. Meaning responses is not placebo. Unfortunately, many have labeled placebo that this mannerisms and your therapeutic alliance is placebo. I don't think so. In fact, if we look at the research specifically on meaning responses, this was a meta-analysis of 37 acupuncture trials with a total of over 5,000 patients. And this was a recent paper. And they reported a large meaning response effect, which made it difficult to detect small additional specific effects of the actual treatment. Okay, well, that's acupuncture. We don't do that. We don't have to worry about it. Well, then turn to Werneke in Spine of 2014. This was very surprising. Now he did a meta-analysis of spinal manipulation studies. Okay, that's getting closer to what we do. We all love to be hands-on and learning different techniques and things like that. Well, of the 336 spinal manipulations that were included in the meta-analysis, meaning responses explained almost 90%, 97% of the outcomes for acute lower back pain, and 3% of the variance of the outcome was explained by this specific manual technique. What? That's a little bit unusual from what we would hear. And 67% of outcomes for chronic lower back pain were controlled by this therapeutic alliance or meaning responses. And only 32% of the treatment was actually explained by the treatment effect. And they suggest that the treatment effect, the most beneficial effect, was exercise in a supportive environment, not necessarily how you manipulated the patient. So, I mean, that really ruffled a lot of feathers in the manual therapy world. But it's something to look at. It's just a study, okay? But it's an interesting look at what's going on and how we explain outcomes. So I think after a total literature review, I think this statement is very strong. And that is therapists who are skilled at enhancement of meaning responses, meaningful responses, while embracing evidence-based interventions, okay? These are adherent therapists who embrace meaning responses. You can't wave a magic wand and be a cheerleader. Let's go, 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 go. That doesn't work. You have to use evidence-based interventions adherent to clinical practice guidelines, heap on therapeutic alliance, and you're going to produce the best outcomes. And that's what Linda Resnick showed way, way many years ago. So I think that those are the types of therapist characteristics that achieve best patient outcomes. Not how strong or how great your manual techniques are per se. Okay. Now, advanced cognitive behavioral programs. They really fit our wheelhouse, okay? And this is how you want to start thinking about those. This, by the way, is the START tool. And they're going to start telling you, well, what's the type of treatment you should do based on the patient's classification. And if you turn this tool on in photo, it's printed right there for you. It tells you, this classification is high, this is medium or low. So if you're looking at this data, you can use that data to start augmenting or starting with cognitive behavioral treatment strategies. Remember, you have so many things in your toolbox. What does the data tell you to use now? And if the distress is reducing, well, now you better come manual. Now this specific core trunk strength, now this is becoming useful. Okay, so you have to be willing to look at the data to see what's most important. So we're not going to integrate this with our traditional core type of exercise, manual therapies, et cetera. We're just look at cognitive behavioral. All right, so what I would suggest, if they're classified as low, just use meaning responses to augment your treatment strategies. Build a good therapeutic alliance with your patients. Just do it generally. If they're medium or high, there's more formal cognitive interventions recommended for physical and occupational therapists. And are we okay? You know? Well, this is a nice interlude. Is that saying we're over? So I think they must be watching a good movie over there. And maybe it's the new Star Trek release. I don't know, whatever. But anyway, so formal, task-specific exercise approaches was graded exercise or operant conditioning program. This is not new stuff. This is a strengthening program where it's time contingent, not pain contingent. Yeah, I know you feel pain, but let's keep go, go, go. This was originally published by Fordyce, a long time ago. And now I choose not to use this because as a value-based clinician interest in efficiency, this is not efficient. This takes a long time, usually. So I tend to go with graded exposure program, exposure in vivo. The interesting authors that have talked about this over and over again since the early 2000s, Vlayen as well as Krombez's research. If you want more articles on this, you can let me know. My email is in there if you need more articles. But graded exposure program, I love this program. This is very effective. And it's really based on a 5-step process. And first starts with education. You develop a hierarchy of tasks and activities reported as least to most difficult. You have practice-specific activities and tasks. This is where you're exposing the patient to what they're afraid of, perhaps. And then task-specific strengthening exercises to support that function. This is not exercise for exercise's sake. There is a paradoxical shift and different change in philosophical principles. You're not looking for necessarily strengthening, which you may, but you want to use that exercise to tell the patient that if they do this, they'll be able to get off the toilet a little bit easier, or something like that. And then involve the patient in problem solving and goal setting. So what is the educational message? I'll go through this quickly. Spine is strong. Stay active. These are the adherent principles when they were talking about not adherent, passive versus adherent, active. Hurt versus harm should be taught right away. Control. You're going to control your pain. You're not going to be cured. You really got to drill that. And so I look at pain as frequency, intensity, and duration. And my goal, I don't want you to be a stock market player here. And you come in every other day and you're monitoring your pain. My pain's low, I'm happy. My pain's high, it's all over. I'm not going to ever get better. Teach the patient not to play pain like the stock market. This happens over time. So this month compared to where you were last month, give them real expectations of what they may have to be dealing with. So we want to control pain. By the way, a 50% reduction in pain is highly associated with high patient satisfaction scores. So yeah, if we can knock down their pain levels by maybe 50%, or the duration of pain, or the frequency of pain, you're on the right track. But you're not curing them. And you've got to turn that around a little bit. And certainly work on this therapeutic alliance, which I think starts at day one when you impart value as to why the patient is filling out that survey. And what I tell my patients verbally, and what our group has been trying to do, is they read their written instructions, and I say to them, listen, the computer doesn't really know who you are, doesn't know if you're 18 or 100, but I really want to know how your impairment this time back is affecting your function and quality of life issues. And you may see questions here from a physical perspective as well as emotionally. If it doesn't apply, don't worry about it. Just hit the closest answer. That's it, and I walk away. If I didn't say that simple short sentence, I had a lot of, this is all in my head, you don't know what's going on, you think I'm making it up. You don't go there. Short, sweet sentence, walk away. I'll only answer it if they really have a question, but answer it as Deanna said, paraphrase it back to them. You'll be amazed how well paraphrasing works. And now, so the second step in this exposure exposure in vivo program is the development of a hierarchy of activities of tasks. And actually, the photo report lists that for you. That's item mapping. And a couple of questions to define moderate activity versus difficulty with recreation, et cetera, is sweet, and it'll set you up on this hierarchical thing very rapidly. Now, do you know Stephen George or his work? So he's very high into the psychosocial component of physical therapy and how to merge that in there. Now, he developed this fear of daily activity questionnaire, and he has his patients fill that out, but it's not efficient. I don't think you need to do this. You can use the photo report to develop this hierarchical list. So you have the lowest level and the most difficult level items that the patient is confronted with. And then again, you use the item mapping to clarify specific additional activities that they express difficulty or fear of doing. So it's important to know which functional tasks are most problematic so that task-specific programs can be designed to target these tasks and activities. And that's the goal of effective item mapping using the photo report. So here's an example. We went over this morning, so I'm just going to go quicker. And then you have to start exposing the patient to the difficulties they think they're having trouble with. How many in here have a vacuum cleaner in their treatment booth? I do. And are you an OT? You're a PT. You have a vacuum cleaner? Okay. Okay, yeah. And I have a mop, and I have shelves, and I have boxes, and I have laundry. So I'm trying to make things very real, so I want the patient to go home and problem solve those issues. Because if they are connected to problem solving, then I know they're engaged in their thinking. Okay? So you really spend your time during that session teaching. The message is when they leave, go home, problem solve. The next time I see you, come back with questions on what areas you've had difficulty doing, and we'll start solving those together and see how you perform. Then take that and go on again. It's a very effective strategy. I have tons of research and published that if you see changes in that distress serially, so they're at high risk, medium risk, and low risk over serial assessments, that's a huge external marker that you're on the right track. With that said, if you're applying these strategies and they stay high, well, I can tell you within 3 weeks, you might as well discharge. Because there's something going on that's confounding any improvement in FS. I've never seen a patient at high risk over serial assessments who achieved predicted. No, if they did, it was, I don't know, it was an outlier. I haven't seen it. And the people who are collecting STAR tool, is that true? Would you see that? Picking on you guys because I know you're doing the STAR. Is that what you would see also? I mean, is that normal? You would see a reduction in the distress. So it all goes back to, well, we don't treat the distress, we treat the function. And if the distress is linked to the dysfunction, we solve the function, then the distress disappears. If you're not being effective at doing that, then I think these psychosocial factors are very good external markers to decide if I can't be effective, I need to be efficient. And that takes a little bit of skill. You're not going to go out tomorrow and turn on the STAR tool and then all of a sudden make these great decisions about what you need to do, and I can't help you in your discharge. I don't think that happens that quickly. You have to start getting used to this and seeing changes occur. And basically, you're asking them to perform these tasks. Why? Because you want them to correct the patient's misconception of pain, hurt versus harm principles. And that's what we all do. We now have to formalize it and make it meaningful in our treatment toolbox to affect patients' perceptions, change their beliefs and behaviors. And I think we can do that. So this certainly is a physiological shift in strength training. This is a very interesting read in Stephen George's paper in 2009. But again, you're using exercise from a different shift, your paradigm shift here. Well, you know, I'm not just wanting to get you stronger. I do, but I want to get you stronger because I know you're going to be able to go up and down the stairs better. So let's work at stairs and see how much strength you need to be doing to get to this goal, that type of thing. So I may have the patient be carrying groceries instead of just pumping iron. Or if they are pumping iron, the purpose is because I want you carrying groceries over the next several days before I see you again to see how it made out. So I might introduce core trunk strengthening and other components to make them more successful in thinking about how to improve carrying groceries. Or instead of just doing a sled, I may change that and have them push a table or cabinets, push and pull. Have them actually try it out. Because you want them to go home or at work and apply these principles so they can be successful. And then to educate, again, the purpose of the exercise is linked to improving their ability to perform the task. Ryan said that very nicely this morning. Okay. And again, you would break, this is where your biomechanics becomes very important because you can break down the particular function and make it into different biomechanical components that you could address with your exercise. And then to develop them in problem solving. By the way, the only caveat here is you want to do this across a wide variety of work and home tasks. So we know that they have a lot of, the item mapping is really important here because, well, just because you resolve their problem lifting groceries from the floor, you might not have done anything in relationship to going up and down stairs. So the correlation of improving one item does not carry over to other items. So you need to be looking at all these items together and addressing each one of them as time allows, and you can do that efficiently. So you want to, again, and this was a good reference on that, Crombez in Health Psychology of 2002. There's so much that we are learning from psychology literature, and now physical therapists are publishing that in a physical therapy rehab setting. Key message comes back, seems the same all the time, hurt versus harm. You know, although your back hurts, does your back limit you from doing this task? So they would be going up and down. So they tell me they have extreme difficulty going up and down stairs. Well, we may go up and down stairs and say, oh, Mr. Smith, did you have a lot of difficulty performing that task now, going downstairs? No, it's fine. Okay, so I want you to do is go home, and when you go up and down stairs, assess how you're feeling. So this is just an example of multiple things that you can be thinking about, changing their focus that they are able to perform these tasks successfully. All right, that was a really quick synopsis. I'm sorry I talked so fast, but I guess what time is it? It's getting late. And it's amazing that you all won. You all stayed. Okay, you can turn off the videotape now. Everybody was awake. Okay, good.